Hi, I'm Chrissy Goss. I'm a nurse practitioner here at High Risk Obstetrical Consultants in Knoxville. You've been diagnosed with gestational diabetes, and we have decided to make a video for you so you can have a better understanding of your diagnosis, risks and complications, the physiology, so you have a better understanding of what's going on in your body. So we'll have you watch this video before your initial visit at our office. So the first thing I want to cover is physiology behind gestational diabetes. So you eat your food, it travels into the small intestine. That's where carbohydrates are broken down into glucose. The glucose then enters your bloodstream, which stimulates the pancreas to release insulin. The job of insulin is to open the doors to the cells of the body and allow the glucose into your cells for energy and nourishment. So we can safely assume most likely you have a genetic flaw in this pancreas where it's not working as efficiently as someone with different genetics. So you might be predisposed to diabetes. And also we're pregnant, so we have all these hormones from the pregnancy and the placenta interfering with insulin and making it hard for it to do its job. So between the two of those, we end up with elevations. So what we want to try to do is smaller amounts of carbohydrate more often throughout the day. Instead of 3 large meals, that might overwhelm your pancreas. Sometimes that's enough to control the blood sugars. Sometimes we have to add in medicine. So now, as we go through the pregnancy, the hormones continue to rise. So your insulin resistance tends to get worse as we go until about 36, 37 weeks, and then those hormones level off. Once you deliver the baby, the placenta's out, these hormones should drop off. Diabetes should be gone very quickly after delivery. We will recommend that you have a 2-hour glucose test 6 weeks postpartum as follow-up. This can let us know, how are you outside of pregnancy? Are you pre-diabetic? Do you have type 2 diabetes? Has this gone away? And what follow-up do you need in the future with your primary care? Now the next thing I want to talk about is how to test your blood sugars. So if you don't already have a glucose meter, we can call one in for you. You can bring it to your initial visit. We can show you how to use that glucometer properly. So important things when you check your blood sugar is to have clean, dry hands. Warm, soapy water, dry hands is best. If you don't have a sink available, you can use an alcohol swab, like rubbing alcohol, but make sure your finger's dry before you poke your finger. If you use hand sanitizers, gels, and foams, those tend to have aloe in them, and that could possibly skew your number higher. So we want to avoid using the hand sanitizers. When you get your meter, you have strips that come with it. Those are sensitive to moisture. You want to keep your lid on tight. Don't store them in the bathroom. Extreme temperatures can mess up your strips, so try not to forget them in the car. Now, we want you to start checking your blood sugars first thing in the morning, a fasting blood sugar. That's preferably an 8-hour fast overnight. That's what's most accurate. I wouldn't go over 10 hours fasting. That's not really recommended. So if you can get to close to 8 hours, that is what we prefer. We also will have you check an hour after you finish eating breakfast, lunch, and dinner. We have these purple cards that you're going to be keeping your blood sugar log on for us that you'll bring to each visit, and they should make a copy at the front desk for us. In the first column, it has the date, so you write the date here, and then we'll have the fasting blood sugar in this column, and then 1 hour after breakfast, lunch, and dinner. So if you can keep good logs for us, that helps us know how well we're managing with your diet versus whether we need to add in medicine. Our goals for pregnancy will be less than 95 for the fasting, less than 130 1 hour after you finish your meals. So please bring your cards to your visits. We'll give you these at your initial visit, and also if you want to bring your glucose meter, like I said, you can bring that and we can help you with it. The next thing I want to talk about is risks and complications. Why do we worry about gestational diabetes in pregnancy? There's some risks and complications if we're not good at controlling our blood sugars. One of those is overgrowth of the baby. So we can end up with really large babies if we're not careful. They tend to store extra sugars, fat in the upper body. So we can end up with a large baby that's also wide at the shoulders. This can lead to problems with a vaginal birth where the head comes out and the shoulders have gotten wide and could possibly get stuck behind the pelvic bone. That can lead to birth injury, increased risk for C-section. So we really want to have good control of our blood sugars to decrease the risk of overgrowth of our baby. Another thing that we see is extra amniotic fluid building up if we have a lot of high blood sugars. Babies tend to get thirsty with high blood sugars just like we do, so they'll drink more and urinate more if they're exposed to higher amounts of sugar. So that amniotic fluid can build up, add extra strain to your uterus, and could possibly trigger preterm labor and early contractions. So we want to have good control, and that's one thing. You'll have ultrasounds where they measure the fluid around the baby, so they will be watching for that along with the baby's size. In the 3rd trimester of pregnancy, the baby's lungs are finishing developing. The baby produces an enzyme called surfactant. Surfactant allows their lungs to become stretchy so they can breathe easily after birth. If we have a lot of high blood sugars during that 3rd trimester, that interferes with the production of surfactant. So babies of poorly controlled diabetics are more at risk for respiratory issues after delivery. So we really want to have good control so those lungs develop on time and baby can breathe easily after they're born. Now there's also an increased risk for preeclampsia if you have diabetes in pregnancy, so that is a good reason also to keep good control so we don't have issues with preeclampsia and blood pressure issues towards the end of pregnancy. Now once the baby's delivered, we cut the umbilical cord, we cut off sugar between you and your baby. Sometimes then they'll drop low, especially if they've gotten used to higher blood sugars, and then we cut the source off. So we really want to go into your delivery well controlled to help prevent a low blood sugar in your newborn, and also have you feed your baby as soon as you can after delivery. The nurses will check the baby's blood sugar on their foot like we do our fingertip, and they'll make sure that it's staying in a safe range for the baby. If it does drop too low, sometimes they want to give some glucose water formula to boost that back up. So you can talk to your nurse about how the baby's blood sugar is doing. There's increased risk for jaundice with these babies as well, so you want to watch for yellowing of the skin in the eyes after delivery, and certainly the baby needs to check in with the pediatrician typically within that 1st week after discharge from the hospital. Now these are the main risks and complications, not meant to scare you. It's just a reason why we're making you poke your finger and keep logs and come to extra visits due to your high risk status with having gestational diabetes. Now just to reiterate, we're going to have you start checking blood sugars, fasting, and 1 hour after you finish your 3 main meals, and bring those logs to your visits. We'll also have you start a controlled carbohydrate diet, which Lauren, our dietitian, will be explaining to you as well in a different video. Pause for a minute.